Hello everyone, I am Docsaab and it's my pleasure to welcome you to this presentation on acute watery diarrhea. This presentation is designed to provide you with a detailed overview of the most effective management strategies for pediatric patients suffering from acute watery diarrhea. We will be walking through the definitions, assessment methods, and treatment protocols aiming to enhance our collective ability to care for children with this condition. My goal is to ensure you live with a clear understanding of these vital guidelines. Let's start by clearly defining acute watery diarrhea as per the IAP guidelines. It is characterized by a significant change in stool consistency leading to the passage of loose or liquid stools or an increase in the frequency of bowel movements to 3 or more within a 24-hour period. These episodes typically last for 7 days or less and can occur with or without accompanying fever or vomiting. It is crucial to understand what acute watery diarrhea is not. For instance, frequent passage of normally formed stools or the often loose pasty stools observed in exclusively breastfed infants are not classified as diarrhea. Regarding its etiology, viruses are the predominant cause, accounting for over 60% of cases, with rotavirus being the leading global culprit in children under 5. Bacterial and parasitic infection follow. The pathophysiology is straightforward but critical. The frequent passage of liquid stools combined with vomiting, sweat, urine, and even increased respiratory rate during fever leads to substantial losses of water and vital electrolytes such as sodium, chloride, potassium, and bicarbonate. If these losses are not adequately and promptly replaced, the inevitable and dangerous consequences is dehydration. Assessing the degree of dehydration is arguably the most critical step in managing acute watery diarrhea as it directly dictates the urgency and type of intervention. The guidelines use a practical 3-level severity scale primarily based on easily observable clinical signs. For severe dehydration, clinicians should look for at least two of the following signs. The child appears lethargic or unconscious, has noticeably sunken eyes, is unable to drink or drinks very poorly, and skin pinch test where a fold of skin on the abdomen is lifted takes 2 seconds or more to return to normal. Some dehydration is indicated by two or more of the following signs. The child is restless and irritable, has sunken eyes, and drinks eagerly, often appearing very thirsty. These children are clearly dehydrated but not yet critically ill. Finally, no dehydration is diagnosed when there are insufficient signs to classify the child into either the some or severe categories. This classification is vital for rapid and accurate assessment, ensuring that the appropriate treatment plan is initiated without a delay. While prompt clinical assessment is a key, it is equally important to know when a diagnostic workup is warranted. For the majority of children with acute watery diarrhea, routine diagnostic investigations are typically not required. The focus should remain on rehydration and supportive care. However, in severe conditions or within a hospital settings, further investigation may become appropriate, especially in individual cases where the clinical picture is complex or atypical. Microbiological investigations, that is, stool test to identify the causative organism, should be considered in specific circumstances. These include children with underlying chronic conditions such as oncologic disease, inflammatory bowel disease, or immunodeficiency, those presenting with extremely severe clinical conditions like sepsis, if symptoms persist for more than 7 days, during a suspected outbreaks in settings like childcare, schools, or hospitals, for children presenting with a high fever, or if there is history of recent travel to areas with endemic or high risk diarrheal pathogens. These targeted investigations help to identify specific pathogens that might necessitate a different or more intensive therapeutic approach. The overarching primary goal in managing acute watery diarrhea is to proactively prevent potentially fatal complications. While diarrhea itself can be self limiting, the complications it can cause, particularly in young children, are extremely dangerous and can lead to mortality if not addressed quickly and effectively. These critical complications include severe dehydration, which we discussed earlier, leading to circulatory collapse, metabolic acidosis, a dangerous imbalance in the body's pH levels that can impair organ function, significant electrolyte disturbances, particularly affecting potassium and sodium levels, which can lead to cardiac arrhythmias or neurological issues, and in some severe cases, systemic infection or sepsis. Our entire management strategy, from initial assessment to ongoing treatment, is designed to aggressively counteract this risk, ensuring the child's swift recovery and long term stability. Oral rehydration solution or ORS, particularly the low osmolarity formulation containing 75 millimoles per liter of sodium, remains the cornerstone and first line treatment for acute watery diarrhea across all age groups. The guidelines detail three treatment plans based on the severity of dehydration. Plan A is for children with no dehydration. This involves maintenance at home using ORS or safe homemade solutions. The key is to replace ongoing fluid losses by giving 10 ml per kg of body weight of every loose stool pass with specific age-based amounts. For infants up to 2 months, about 5 teaspoons per purge. For children aged 2 months to less than 2 years, 50 to 100 ml. And for those aged 2 to 10 years, 100 to 2 ml plus free access to plain drinking water. Plan B addresses some dehydration. This requires correction of existing fluid and electrolyte deficits, ideally at a health facility. ORS is administered as a 75 ml per kg of body weight over a period of 4 hours. Close monitoring every hour is essential with a reassessment after 4 hours. If the child is still in Plan B after reassessment, the treatment can be repeated. If rehydrated, they shift to Plan A. For severe dehydration, Plan C necessitates urgent intravenous rehydration in a health facility. Ringer's lactate is the preferred fluid, or alternatives like normal saline can be used if RL is unavailable. The dosages are age specific. Infants receive 30 ml per kg over 1 hour, followed by 70 ml per kg over 5 hours. Older children receive 30 ml per kg over half an hour, then 70 ml per kg over 2.5 hours. As soon as the child is able to drink, oral ORS at 5 ml per kg per hour should be started, and monitoring must be done every half hour to watch for improvement or complications. Beyond rehydration, nutritional and adjunctive therapies are absolutely vital for recovery and preventing future episodes. Firstly, continuous feeding is paramount. For infants under 6 months, breastfeeding should be continued. For all children, regular oral feeding should be reintroduced no later than 4 to 6 hours after rehydration has begun. Even in cases of severe acute malnutrition, food should be offered during the rehydration phase. Secondly, safe home available foods can supplement ORS. These include preparations like rice or dal water, vegetable soup, salted lassi, sikanji, and coconut water. Plain water can also be given in between. It is important to avoid restrictive elimination diets as they often do more harm than good. Zinc supplementation is highly recommended due to its proven efficacy in reducing both the duration and severity of diarrhea and in preventing further episodes for up to 3 months. The recommended dose is 20 mg per day for 14 days for children aged 6 months to 5 years and 10 mg per day for 14 days for infants aged 2 to 6 months. Probiotics can also serve as a beneficial adjunct to ORS. Selective strains such as Lactobacillus rhamnosus GG, Saccharomyces boulardii have shown effectiveness in reducing the duration and intensity of symptoms. Finally, for persistent vomiting that hinders oral rehydration, antiemetics can be considered. Ondansetron, administered either orally or intravenously at a dose of 0.15 mg per kg per dose with a maximum of 8 milligrams, can effectively reduce vomiting and facilitate fluid intake. It is crucial point to understand that routine antibiotic use is generally not recommended for the treatment of acute watery diarrhea. Most cases are viral and self-limiting, and unnecessary antibiotic use contributes to antimicrobial resistance. However, there are specific indications where the use of antibiotics is justified and beneficial. These include infants under 3 months of age who are more vulnerable to severe infection, children with underlying chronic conditions such as immunodeficiency or severe acute malnutrition, confirmed or highly suspected bacterial infections like Shigella, enterotoxigenic E. coli, Vibrio cholerae, and Yersinia enterocolitica, any signs of invasive bacterial infection. When antibiotics are indicated, specific treatments are recommended. For Shigella, ceftriaxone, cefixime, or ciprofloxacin are options. For non-typhoidal salmonella, usually only in high-risk children, parenteral ceftriaxone or oral azithromycin or ciprofloxacin might be used. Enterotoxigenic E. coli infection can be treated with azithromycin or cefixime. For Vibrio cholerae, a single dose of doxycycline for children over 2 years or a single dose of azithromycin ciprofloxacin is recommended. This targeted approach helps us ensure effective treatment while minimizing the risk of resistance and adverse effects. Managing diarrhea in children with severe acute malnutrition requires a distinctly differing approach compared to non-malnourished children as their physiological response are compromised. Diagnosis begins with a careful history. Look for definite history of sudden onset diarrhea, any recent change in the child appearance, the mother's observation of sunken eyes since the diarrhea started, and eagerness to drink. A severe acute malnutrition child in shock present with specific signs, cold hands, a slow capillary refill time greater than 3 seconds, and a weak and fast pulse. These are critical indicators requiring a immediate attention. Management for same children with the diarrhea must occur in healthy facility settings. Oral or nasogastric rehydration is preferred. Intravenous fluid should be used only for the treatment of shock due to the significant risk of overhydration and subsequent heart failure in these fragile patients. When rehydrating, a modified ORS protocol is essential. Oral rehydration should be slow, typically 70 to 100 ml per kg over 12 hours, starting with a rate of 10 ml per kg per hour in the first 2 hours, then alternating with starter diets. Crucially, full strength ORS solution should not be used as it provides too much sodium and too little potassium for malnourished child. Instead, either a specifically modified ORS prepared by dissolving one standard 75 ml per liter sodium ORS packet in 2 liters of clean water, then adding 45 ml of potassium chloride solution and 50 grams of sucrose, or a rhizomal rehydration solution for malnutrition which has high potassium and low sodium content should be used. To conclude our presentation, let's summarize the key takeaways and emphasize the importance of prevention. Firstly, vaccination is a cornerstone of prevention. Ensuring children receive up-to-date immunization, especially for rotavirus and measles, significantly helps in preventing diarrheal diseases. Secondly, early intervention is paramount. Prompt and accurate assessment of dehydration status, followed by appropriate rehydration therapy, is crucial to prevent adverse outcomes. Thirdly, comprehensive nutritional support is non-negotiable. Continuing feeding during illness and providing extra meals for 1 to 2 weeks post-diarrhea aids recovery and helps prevent a recurrence. Fourthly, we advocate for targeted therapy. This means judicious use of zinc supplementation, appropriate application of specific probiotics, and highly selective, indicated only approach to antibiotics, avoiding their routine use. Finally, maintaining SAM awareness is vital. Clinicians must be able to recognize and manage diarrhea in children with severe acute malnutrition using a specialized protocols, adapting fluid management to their unique physiological needs. By adhering to these standard treatment guidelines, we can significantly improve outcomes for children suffering from acute watery diarrhea. Thank you for your time and attention, guys. Please feel free to reach out to me via comments with any further questions. And please like, share, and subscribe to the Docsaab's Diary.